My, my name is Peter Wayne, and I serve as the director for our center. Today, I have the honor of introducing our guest speaker and a good friend of mine, Dr. Jun Mao. But before doing that, a few practical announcements. First, if you wish to request a continuing medical education credits, please be on the lookout for a note in the chat feature from our coordinator, Dan Litranek, and he will provide detailed instructions. And second, as you listen to Dr. Mao's presentation, we encourage you to write questions for him using our Q&A feature. I'll be collating these and present them to him during the Q&A discussion session following his presentation. So I'm delighted that Dr. Mao accepted our invitation to present here today. Over the past 4 years, I've had the privilege of getting to know Dr. Mao, or Jun as we call him, through our work together on the Society for Acupuncture Research Board. And I've been so impressed and moved by his intelligence, his passion for his work, and his pragmatism and ability to get so much done. I trust you'll see what I'm talking about firsthand in Dr. Mao's presentation today. Dr. Mao is the chief of the Integrative Medicine Service and the Lawrence S. Rockefeller Chair in Integrative Medicine at Memorial Sloan Kettering Cancer Center and professor of medicine at the Weill Cornell Medical College. He's a board-certified family physician with added qualifications in hospice and palliative care. He's also an experienced and licensed acupuncturist who combines Western and Eastern approaches to manage pain and symptoms in cancer patients. Dr. Mao's program of research focuses on investigating the effects of mechanisms and integration of complementary and integrative medicine for symptom management in cancer. He has advanced research training in clinical epidemiology and extensive experience conducting acupuncture, pain, and symptom science clinical trials, as well as health services research amongst cancer patients. Dr. Mao has received extensive support from the National Institutes of Health, the Department of Defense, PCORI, and the American Cancer Society for his work. He's published over 200 peer-reviewed articles. And he's been the past president for the Society for Integrative Oncology. And as I mentioned before, he's the co-president of the Society for Acupuncture Research. And his findings have been included in the American Society of Clinical Oncology, National Comprehensive Cancer Network, SIO Clinical Guidelines for Developing Evidence-Informed Integrative Oncology Practices for Standard Cancer Care, and many other distinguished venues. So without any further ado, please join me in welcoming Dr. Mao.
Thank you, Peter, so much for that wonderful introduction. Good morning, everybody. It's so great to meet with all of you virtually. I'm going to share my screen. So today I'm going to talk to you about integrated oncology, evidence-based medicine meets patient-centered care. So I receive research funding for doing the work I do from NIH, PCORI, DOD, and the ACS, as well as some herbal research supported by the Tibetan Medicine Company, which I'm not discussing the specific research on that for today's talk. So the learning objectives for today's talk is I'm going to try to present the definition of integrated oncology and key therapeutic approaches. I want to discuss how to use rigorous research to increase the evidence base for integrated oncology, and then to discuss how we apply this integrated oncology practices in patient-centered care. So the use of complementary and alternative medicine, known as PAM, is extensive throughout the world. In the US alone, using the 2007 National Health Interview Survey, I have demonstrated that 6 out of 10 cancer survivors has used a type of CAM approach in their lifetime, with 4 out of 10 have used in the previous 12 months. When compared with individuals without cancer, cancer survivors tend to use CAM approach when they perceive conventional medical treatments are not helpful. They are also more likely to be recommended by their physicians and nurse practitioners or social workers to use CAM. They're equally likely to use CAM on the recommendation of family, friends, and co-workers. However, there are subset of people in the pursuit of CAM, they forgo conventional treatment. The consequence can be very detrimental. This is analysis looking at individuals who with curable breast cancer, when they forgo conventional treatment in the pursuit of alternative cancer treatment, their overall survival by 5 years has almost less than 25% absolute difference in survival, which is really quite alarming. So on one hand, you have so many people who are interested in using this CAM approach. On the other hand, and if you forgo conventional cancer treatment, the survival can be compromised. The patients don't have to choose one versus the other. Really, there could be an integrated approach. In 1999, with a generous philanthropic gift from Mr. Lawrence Rockefeller, the Memorial Sloan Kettering Cancer Center has designated a first integrated medicine service in a comprehensive cancer center. So I had the fortune to become the second service chief, followed by Dr. Barry Cathlet. And our goal is to really challenge our cancer care delivery to take risk and to help we take care of mind, body, and spirit of the individuals impacted by cancer. Today, I work with close to 60 talented faculties and staff, really committed to improving patients' lives, as well as producing high quality research to increase the evidence base for integrated oncology. I also had the fortune to work with many individuals in the United States and around the world, including Dr. Ligable from Harvard, to really build integrated oncology as a field. So integrated oncology is a patient-centered, evidence-informed field of cancer care that utilizes mind and body practices, natural products, and or lifestyle modifications from different traditions along conventional cancer treatment. So the key qualifier is patient-centered and evidence-informed. Integrated oncology aims to optimize health, quality of life, and clinical outcomes across the cancer care continuum and empower people to prevent cancer and become active participants before, during, and beyond cancer treatment. So a lot of people tend to feel like if you're doing CAM, that's the opposite of evidence-based medicine. I want to illustrate that is a false assumption. And how do we use research to gradually move our field from a more experience-based to evidence-based? In the 1980s, Sack et al. Have defined integrated medicine, evidence-based medicine as the integration of best available research evidence with our clinical expertise and our patients' values and circumstances. So the bottom line is evidence from research is only one of the three key pieces in performing evidence-based medicine. So a clinician expertise matters. Patients' preference and values matter. Certainly research evidence matters. So let's demonstrate the principle of this using a patient case. Let's meet Jada. Name is not real, but really the scenario is pretty real. So Jada is a 55-year-old woman diagnosed with stage 2 ER-positive breast cancer. She had chemotherapy. She was prescribed with a drug called anastrozole. It's a type of aromatase inhibitor, hormonal treatment for postmenopausal women. She's been on this drug for 6 months. She came to my clinic. My body just aches and aches. I'm only 55, but I feel like I'm trapped in an 80-year-old body. I love to play tennis, but now I cannot do it anymore. My elbow, my shoulder just hurt. I just wonder whether I should continue this drug. So aromatase inhibitors, the hormonal treatment is a mainstay for preventing cancer recurrence in ER-positive breast cancer. Unfortunately, this type of drug have a lot of toxicity. So I met Jada in 2007 at the beginning of my career. At that time, there's very little understanding on this phenomenon. So my very first study was supported by American Cancer Society's institutional pilot work. So we did a survey setting on 300 women on AIs. and found that 1 in 2 report joint pain either worsen or starting after start on this drug. Then we got additional pilot institutional funding to demonstrate that systematic low grade of circulation in the blood, such as CRP or taxine, MCP1 or vitamin D binding protein, associated with experience of pain, fatigue, and insomnia in women with breast cancer. And furthermore, working with a postdoc, Justin Brown, who is now attending at Pennington, and we found that individuals with this type of pain also report a twofold higher rates of reducing physical activity, which is critical for healthy aging in breast cancer survivors. And last but not least, working with a psychology PhD student, Mariah Breyer, we found that when individuals experience pain and they perceive pain make them aging rapidly, they're 70% more likely to stop this drug. So again, sometimes when oncologists feel like pain is just pain, but pain decrease quality of life, pain decrease functions, pain decrease adherence, life-saving cancer treatment. So it's not just a quality of life issue, it could be a survival issue. So let's look at what intervention can potentially be helpful. So Dr. Don Hirschman from Columbia University led a multi-center SWOG study. It is a double-blind, sham-controlled acupuncture trial involved 226 women with breast cancer. Patients are randomized 2 to 1 to 1 to true acupuncture. Sham acupuncture is really acupuncture practice look like real, but really located at different locations than the real acupuncture point, and weightless usual care group. So the individuals in acupuncture groups receive twice weekly treatment for 6 weeks. The primary outcome measurement is a brief pain inventory worst pain score measured at week 6, at the end of the treatment. And the 2-point reduction is considered clinically meaningful. So this paper was published in JAMA, received a lot of press coverage. So when you compare the true to sham to weightless control, it showed statistically significance. However, sham did not show any difference compared with usual care. And then if you use the 2-point as the clinical meaningful reduction to change that to in the responder analysis, you find about 60% the people who received true acupuncture were responders, which the rates are much higher than those receiving sham or weightless control, which is about 30%. And the number to treat is about 1 in 3 patients will benefit from the use of acupuncture to treat arthralgia. This year, building on other people's work as well as my own preliminary data, we published in JAMA Oncology, the largest acupuncture trial for chronic musculoskeletal pain in cancer survivors called the PEACE trial. What is novel about this trial is not comparing acupuncture versus sham versus doing nothing. It's comparing 2 types of acupuncture, electroacupuncture, auricular acupuncture versus usual care on pain in survivors experiencing chronic musculoskeletal pain. Our primary hypothesis is that both these interventions will produce greater reduction in average pain intensity compared with usual care at week 12. And our secondary hypothesis, auricular acupuncture as effective as EA in reducing average pain intensity. So people are randomized in electroacupuncture, auricular acupuncture, and usual care. And after 12-week assessments, we follow individuals for additional 14 weeks to determine the long-term durability. And here's are some pictures for the electroacupuncture. In electroacupuncture, we put needles in, then we hook with a TENS unit providing low-dose electric current at the needles. Some people ask me, oh, will I be executed? The answer is not. It's just providing a very localized stimulation to the needles. And in animal research, electroacupuncture have shown to produce endogenous opiates as a low hertz electric stimulation. And the auricular acupuncture, we use the battlefield acupuncture technique, really up to 10 points in both ears. And as you can see, the needles are very different than the traditional acupuncture needle. This kind of needles stay in your ear for 3-4 days before being removed. And the military has used type of technique a lot in reducing pain for our soldiers or veterans. This technique is much easier to learn than the traditional acupuncture. And then in the usual care group, people can continue to receive their medications or go to physical therapy. We recruited an incredibly diverse population with about 30% men. Traditionally, most of this type of trials are focusing on breast cancer survivor only. We have also survivors of lymphoma, prostate, other type of survivors. We have 24% are non-white race, and 44% are people 65 or older, and 28% are less than 55 years old. And the average pain duration is 5 years, and the average year since cancer diagnosis is 6 years. Clearly, this type of pain are chronic. They're not like acute. So they really can impact a cancer survivor's quality of life for many years beyond their cancer diagnosis. And here are results. So the deep gray is the electroacupuncture. The light gray is auricular acupuncture. The orange line is usual care. So by the end of the intervention, the electroacupuncture reduced pain by 1.9 points compared to usual care. The auricular acupuncture reduced pain by 1.6 points compared with usual care. In our non-inferiority testing, unfortunately, we found that the auricular acupuncture was actually inferior to electroacupuncture. So our hypothesis for that testing was not established. However, both interventions improve the pain-related functional interference. They improve patients' quality of life and reduce analgesic use. And the decrease in analgesic use, as well as the improvement in pain and other patient-reported outcomes, were all maintained at 24-week follow-up. So suggesting the effect of acupuncture is not short-lived, they're actually persistent. So the auricular acupuncture had more side effects related to the ear discomfort. Some people cannot tolerate the pain or discomfort. There are about 10% of individuals has to stop the treatment versus the adverse events in the electroacupuncture group was incredibly rare. Just a little bit, maybe bleeding or the local soreness in the needle insertion area. So overall, we conclude that both EA and the auricular acupuncture are effective for pain and pain-related functions. However, auricular acupuncture is not as effective as the electroacupuncture and also was associated with greater side effect. So with research from many people over the last 20 years, today, in the National Comprehensive Cancer Network, acupuncture is recommended as one of the treatment options for treating adult cancer pain, nausea, vomiting, cancer-related fatigue, and also used in palliative care setting, as well as in survivorship setting for treatment of hot flashes. So this cannot be possible without researchers and patients to work together to really conduct high-quality research to gradually put this into guidelines and put this in implementation. So when we talk about integrated oncology, patient preference, values, and rights are incredibly important because I do not believe there's going to be a one-size-fits-all approach. So in early part of my career, I was funded by a career development award by American Cancer Society. For that study, we did a qualitative semi-structured interviews among 25 Black and white breast cancer survivors to look at what kind of attitudes and beliefs drive their use of complementary therapies like acupuncture. Here are some direct quotes from the patient. A 69-year-old African-American woman said, "I hate pills. I have enough of them to take as it is." A 45-year-old Caucasian woman was saying, "Because I think as a cancer patient who has had cancer and has been treated by very invasive means, surgery, chemotherapy, radiation, you don't want another foreign object," she meant by medications in your body to treat symptoms. I'm not like the person who likes to take pill. So I think acupuncture may be a little bit more natural for you. That's another African-American patient. And this last quote is often shared by older patients. because I'm taking enough medicine now. I take 6 pills, 7, 8, 9, 10 pills a day. That's just too many pills. So she was very hesitant to get another pill to treat her hot flashes. So clearly, I think there are many patients who are hesitant to adding another medication for treat medication-induced adverse events. So I think having treatments like acupuncture being available can really expand the options for survivors, so they don't have to suffer between enduring symptoms versus, finding the treatment is more aligned with their treatment beliefs. However, acupuncture is probably not the right solution for everybody. In this survey study of close to 600 women with breast cancer, when we presented acupuncture versus medication as an option for treating pain, about 27% prefer acupuncture exclusively, 26% prefer medication exclusively, and 47% really have no clear preference. So the higher expectations, higher education, white race, as well as family and healthcare provider endorsement, holistic health beliefs, and lower perceived barriers are associated with greater preference for acupuncture to treat pain. So this, as you can see, is not only related to how patient belief structure, is also related to whether family and healthcare providers educate patients about the use of this type of therapy. And following, we also done that greater barriers are experienced among minority patients or patients with less education, with the biggest barrier is the lack of knowledge, followed by insurance and costs. So clearly, I think grand rounds like this are really important to educate patients as well as health providers about where the evidence base for integrated medicine to treat symptoms. So hopefully we can then help our patients learn more. But then also more fundamentally, we need to find more sustainable insurance policy to really help patients from an underserved population access this type of therapy. The good news is acupuncture was just being endorsed by CMS to cover for the treatment of low back pain about 2 years ago. So over time, the coverage for acupuncture for pain management at least will likely increase. So let me also dive into some other evidence for other therapies. So first, talk about music therapy. This is probably one of the most common available integrated approach in the inpatient setting. So we did a program evaluation project recently published in JCO Oncology Practice. When we compare a more passive music therapy, such as just listening to relaxing music or songs, versus more active music therapy, meaning like patient participate in creating the music or creating the songs. So we found active music therapy was associated with greater reduction in cancer-related fatigue. And also in qualitative analysis, we found there's some unique attributes, such as the active music therapy patient really commented on how interactive, stimulating that is. And also patients have the opportunity to have joyful interactions. However, patients don't want the session to be too long because that may be a little bit too stimulating. However, on the other side, on the passive music therapy, really the patients really comment on how calming and how really help them to focus and reflect, and they prefer longer therapy sessions. So I think this type of work help us to begin generating hypotheses. Maybe there are different type of music therapy delivery to target and for desired outcomes, because I think a lot of time people, when they talk about integrated medicine, they can only talk about this sort of very generic, diffuse, holistic experience. However, if we want to make it elevate to the degree of integrated medicine, we have to have some precise outcome that integrative approaches can improve. Meditation or mindfulness-based reduction or mind-body interventions are incredibly important for cancer patient survivors. In this study, Dr. Linda Carlson from University of Calgary have demonstrated mindfulness-based cancer recovery program was more superior to reduce stress improve quality of life and social support, as well as to help with the cortisol level, which is a stress marker associated with stress. And later on, she did a subgroup analysis for individuals who donate samples for telomere analysis. Again, chronic stress can be associated with shortened telomere length. So in this study, her group found that having the psychosocial support either by the MBCR or the supportive expressive therapy, those individuals, they maintain their telomere length versus in the control group, the chronic stress can continue shorten the telomere length. Clearly, this is quite important for a cancer survivor. Often, even after cure with cancer, they can still live with fear of recurrence, as well as chronic stress and anxiety. I know some of the Dana-Farber colleague, Dr. Hall, is doing some study on fear of recurrence. And I think we not only need to help patients to feel better, sometimes feel better can also have biological consequence. And in this study, I know Dr. Wang is really internationally renowned for her Tai Chi work. In this study, Dr. Michael Irwin from UCLA has randomized 90 patients to Tai Chi versus cognitive behavioral therapy for insomnia, which is considered as a gold standard. Here are the results. When you compare with the gold standard, the turquoise blue, the lighter blue shade, the Tai Chi, the deeper blue, actually have almost identical response rate for insomnia. And if you look at 15 months after the start of the therapy, that's a very long time after the end of the 8 to 10 weeks of Tai Chi class. Tai Chi maybe even slightly better, at least the same. So again, I think here we have patients have options. If you want to learn how to change your sleep behaviors, CBT is really great for you. But if you want to really engage your body and mind in a more gentle movement-based meditation, Tai Chi may be the right thing. And then in the analysis Dr. Irwin did is compare with CBTI, Tai Chi actually have added benefit to improve cellular inflammation, reduce circulating levels IL-6, as well as TNF-alpha. Again, a lot of time with chronic stress and chronic depressive or anxious feelings, they're not just feelings you feel in your head, they have been demonstrated again to associate with a low level of chronic inflammation. So it is important for us not to only look at patient-reported outcome, but also look at what are the biological consequence of those stress and worries and lack of sleep. And this study by Dr. Karen Mustin using community cancer oncology group randomized 410 cancer survivors to either practicing 4 weeks of yoga versus standard care. Her study found that really yoga improved almost all domains of sleep, overall quality, the sleep efficiency, and the daytime dysfunction. And also in the yoga group, there's about a 20% reduction of use of hypnotic medications compared with standard care, which is really important. Because if we envision cancer survivorship as a chronic disease model for many years, reduction in hypnotics will help to reduce many of the side effects, such as falls, that can be incredibly detrimental for older cancer survivors' functions, quality of life, and potentially survival outcomes. What about herbs? A lot of people come to integrative physicians like me about, can I take this herb or that? I think often oncologists' approaches don't take anything, right? But in study after study, we found that approximately 20 to 40% of cancer survivors or patients going through active treatment use a type of natural product, and rarely they disclose to their physicians or nurse practitioners because either the doctors don't ask or the patient don't feel like the doctors will respect their opinions. So clearly we have a lot of work to really help to figure out where the evidence is. So we are fortunate to get support from the Lawrence Rockefeller Foundation to build the herbal education and research in oncology program started right at the beginning of the pandemic. Our goal is to advance the research and education of safe and appropriate use of herbs to improve the health and well-being for individuals impacted by cancer. So our conceptual model is a lot of herbs are already available over the counter. People are using regardless whether doctors we want them to use or not, right? So let's learn from the clinic to see what are common use, what are common benefit perceived or side effects. Let's also synthesize the literature on that. A lot of the literature actually is in, say, other language, such as Chinese language for traditional Chinese medicine herbs. And through that, we train researchers and really based on what we can identify as a promising signal from our practice, as well as the synthesis of evidence base to selectively pick highly promising herbal agent for clinical trials. Then once we learn from all this full process, we can try to train clinicians to help them to safely integrate herbs in clinical practice to help meet the needs of the patients. So we piloted a herbal pharmacy at MSK. To our knowledge, this is the first herbal pharmacy in a cancer center program. So started 2009, we have seen a rapid growth in the last year, particularly in the midst of pandemic, when all in-person cares are completely disrupted, we're able to mail the herbs to our patients. So the most common things patients come to see us, for which we may have some solution using herbs, are GI symptoms, immune modulation, fatigue, sleep, and mood, pain, as well as maybe anti-inflammatory. So clearly by doing this, we begin to see where are the unmet needs of the patients, because if patients can have solution met by drugs, probably they're already taking drugs, so they won't be seeing us. So clearly, these are the areas where we probably will focus our research energy on both doing the synthesis of the literature as well as planning for pilot clinical trials. And this is a paper we did looking at the TCM traditional Chinese medicine formula called Maziren. It's a hemp seed-based pill for constipation. So in a systematic review meta-analysis, again, most of the trials are done in mainland China, Hong Kong. There's 1,600 patients included in 17 trials. About 17 trials most are moderate to high risk of bias. There are 2 trials are actually pretty high quality compared with placebo, which we look at conducting meta-analysis, found actually the hemp seed formula was associated with moderate, small to moderate effect compared with placebo for improving spontaneous bowel movement. And we're currently in the beginning phase planning a clinical trial to follow this. And we also maintain one of the most popular herbal website called About Herbs. Since its inception, we have close to 10 million visitors from 228 country with over 30 million internet hits. This can also be accessed through an app download if you have Apple products. And we have about 282 herbal monographs. So if you or your patients are using an herb, you can go to this website to see what are the intended use, what are some of the basic and clinical research, and what are some of the potential drug herbal interactions. Because the use or not use of the herb is a very complex. A lot of patients say, can I take curcumin or can I take ashwagandha? That is not a one size fits all answer. For an early stage patient on a therapeutic trial, the answer is no, because that may have unknown interactions with the investigating agents you have. It can ruin the trial, ruin the health for you, and it's not a risk worth taking. However, for a cancer patient ran out of an option, really want to design, try some herb, we want to work with the patient to select herbs have overall better safety profile, and also as previously demonstrated have some targeted intention to improve whether it's fatigue, digestive systems, or pain. So with that, we can actually measure clinical benefit for the patient. So I think we need to be more nuanced in our approach with how best to integrate herbs in oncology practice, really balance the benefit versus the risk, and to really conduct high quality research to understand both. So this is a way how we envision how integrated oncology can be packaged for patients. This paper was published in the JCO Oncology Practice. You can read for more details. So when we as physicians do integrated oncology consultations, we really focus on lifestyles because they are foundation of health, nutrition, diet, physical activity, sleep hygiene, and the stress management. And then we really try to understand what kind of expectations patients have, whether use on complementary alternative medicine, whether it's for cure, for symptom control, or want to pursue alternative cancer treatment. And try to evaluate what herbs patients are interested in taking, already taking, to evaluate for potential drug-herbal interactions, and to really guide patients towards therapy that have more evidence of benefit as well as low risk for toxicities. And there are sufficient evidence for many of the non-pharmacological interventions for symptom control, such as pain, fatigue, insomnia, nausea, vomiting, neuropathy, dry mouth, and hot flashes. So often for a patient, like say, oh, I want to take this herb for my hot flash, but then when you review the patient, there are some phytoestrogen effects for this herb. If you take long-term, the effects is unknown, the risk may outweigh the benefit, but why don't you try either acupuncture or meditation, which have some evidence from clinical trials, then the patient often are very grateful and amenable to that suggestions. And I just think really this package need to involve patient and their family members to be active participant in the shared decision-making. In our service, physicians are only one piece of the program. We're very fortunate we have dedicated integrated health providers such as acupuncturists, massage therapists, music therapists. All this are available to our inpatient patients, and acupuncture, massage are in our outpatient setting. We're also building an outpatient music therapy program. And for pediatric, we also have dance therapy and martial arts program. And we have a very robust outpatient fitness, personal training, as well as the many mind-body techniques such as yoga, tai chi, and mindfulness. And last but not least, I think really helping guide patients through safe and appropriate integration of herbs is one of the important features of our program. We are not only located in Manhattan, we are also located in all the regional facilities of MSK in New Jersey, Westchester, as well as Long Island. And the COVID-19 pandemic presented enormous challenge for integrated medicine, but also I would say is probably the best opportunity that it presented. We took this as an opportunity to transform our programming online, created a program called Integrated Medicine Home. And during the peak of the pandemic in New York, between April 1st and June 30th, we provided all the programming free to our patients, caregivers, as well as healthcare heroes. We have close to 10,000 participants. And we also did a rapid program evaluation on the implementation process, with over 96 participants are extremely satisfied, 84% reported it helped them to reduce anxiety and stress. And with that, we have progressed this into a really dynamic online membership-based program with very affordable membership rate. So helping people to have access to online live programming on fitness and mind-body practice, as well as workshops. So our goal is to really take advantage of the challenge of pandemic to make something positive out of the experience. Many of our patients really feel like previously they could not come to see us in person in Manhattan just because the travel, the distance, the cost, but now they are so grateful to have the opportunity. Like, for example, we have done a qualitative studies, analyze the themes emerged from some of the focus interviews. So really there are three themes: promote positive health behaviors. Like one patient said, it's great because I try to do exercise on my own, but it's not regular. And this kind of keep me regular, especially when there's someone on the other side encouraging to move or that you can do it. And that is so important for our cancer patients because many of them are going through treatment. They feel emotionally vulnerable and physically weak. to just say, go to do exercise, I can tell you many of the time patients just don't do it. And here you have a dedicated instructor and over 100 other cancer patients doing it together. It can be incredibly motivating. And then also it helps improve cancer patient psychological coping. As a patient, a lot of time, the problem is that you have all this racing thoughts. This classes really make you focus on the current session. And last but not least, patient really valued the community. So this keeps you feeling you're connected to the community and some fellow patients you happen to see are attending the same session. So this provides like a platform for people to continue interacting that way. So certainly we still have a lot to learn about this type of programming, and stay tuned. Hopefully we can continue to improve our way to take care of patients. We also have on-demand solutions on our website to help patients to access for more of the in-moment needs to deal with anxiety, stress, prepare for procedures, scanning or surgery, as well as to help with sleep at night. And this is sort of a pathway we develop for our MSK patients. When patients are preparing, have recently been diagnosed with cancer, they're preparing for their surgery or chemotherapy or start of the radiation. Really, we ask them to participate in our I Am at Home programming. You can do it from home to help you to prepare for those medical procedures. And for patient, on the day of the surgery or in the chemo suite or waiting for the radiation treatment to start in the waiting area, you can access to the on-demand tools to provide some sort of moment-to-moment anchor to help deal with anxiety and stress. And after the medical treatments, whether it's at home or in the hospital setting, to access either inpatient or outpatient integrated approach to address specific symptoms, such as nausea or pain. And then there are many symptoms that are more longer and enduring, and then use our I Am at Home as a way for recovery or access to our outpatient integrated medicine approach to address whether it's neuropathy or insomnia or sort of a xerostomia related to radiation can be incredibly important to help the recovery process. And we believe that to do integrated medicine and to really make integrated oncology part of the standard care, we need more than MSK. That's why it's so great to be here with the world premier program in integrated medicine, the Harvard Osher Center. So really having more education to educate our providers, educate our integrated health practitioner, educate our patients are critical. So we have developed a variety of online educational modules, including a 3-hour fundamentals integrated oncology for doctors or nurses, really to give you more in-depth information than my 1-hour talk, but short enough so you can actually carve out probably in the evening on the weekend. We know how busy our healthcare providers are. And then we also have dedicated continuing program education programming for acupuncture, so music therapists and yoga instructors to help them to learn more about the fundamentals of oncology so they can incorporate sort of a cancer knowledge in the care for their patients. I really want to thank Peter for inviting me to join you for this wonderful morning. I see this picture highlight the path for integrated oncology. It's not always linear. You have to enjoy the process, and the hard work is part of the fun. So hopefully we can work together to really serve our patients, to really address their mind, body, and spirit. So thank you very much.
Jun, that was fantastic. Thank you for such a remarkable presentation. And as I stood up in the beginning, it's just amazing the depth, breadth, and pragmatism of your program and how many people you're reaching in so many different ways. So kudos to you and your team, and all the work and creativity really was reflected in your presentation. We also have so many really interesting questions. So I'm going to give a few of them, and you could do some short answers so we have some time to respect everyone's interests. So one set of questions centers around safety, and they particularly relate to acupuncture. And are there any contraindications, any types of cancer conditions like neutropenia or pancytopenia that might be contraindicated? And along with that, any particular concerns about electroacupuncture versus manual acupuncture? And then with that, can every acupuncturist treat cancer patients, or are there special trainings that would be preferred for a cancer patient?
So Peter, this is really a great question. So with integrated oncology, I think since a lot of the treatments such as herbs and stuff don't have robust evidence of efficacy, so safety is the most important thing, right? So I think with acupuncture or massage, there's definitely need for safety. And for patients with incredibly low white blood cell or low platelet, we have to be very careful when we do acupuncture. So, and we traditionally have some institutional cutoff, but over the years, through some of the work in pediatric population at Columbia, they actually found that adverse events are fairly rare for those conditions if you do it safely. So for example, in people with low platelet, I would try to use superficial needling and never really needle in the area of like abdomen or anything that you have no way to stop the bleeding if the bleeding happens. So I do think the acupuncturists need to really receive oncology specific trainings. I know Dr. Weidong Lu at Dana-Farber is really a leader here. And certainly Dana-Farber program is one of the oldest and most amazing program. And I believe he may do some training in the Massachusetts area, but we also have online training. So I do think you want to work with acupuncturists who have special oncology training and who have experience. Another thing I find is a little bit troubling. Sometimes in private practice, you can make more money if you do longer needle retention or stimulation. Well, for patients who are going through chemo, they're very weak. Actually, I feel like prolonged needling can actually lead to greater fatigue. So you got to really need to be careful. Sometimes you have a patient, I have a patient come to see me, I have done acupuncture, I find I'm just so tired. Then I said, how long were you doing for? Well, I was on the front for an hour, on the back for an hour. I'm sure the acupuncturist made a lot of money, but it's probably not the right thing. I think we have to do what's right for the patient, right? So I do think it's really important to work with practitioners who have additional training, who also have experience working with oncological patients and priority on safety.
Super, thank you. So you mentioned so many of the rich programs available both in person and online, and you talked a lot about the diverse interests in complementary integrative therapies that your patients present. And most of the research that you shared is about one therapy, acupuncture or massage. And given that many patients probably are taking herbs or vitamins while they're learning Tai Chi and getting acupuncture, are you aware of research that's looked at sort of combinations of approaches or sort of a whole system approach? And what do we know about how these therapies interact?
Peter, I think that hopefully will be the question we have the opportunity to begin addressing in the next decade. Because your research, you cannot get a grant funded if there's no foundational work is done, right? I think in the last decade, there have been more evidence for acupuncture, yoga, Tai Chi, meditation. So I think looking forward, I feel like there's definitely opportunity to either packaging or doing more good comparative effectiveness research to understand which treatment is better than what, for whom. So for example, we recently got a PCORI funding to study virtual music therapy versus virtual cognitive behavior therapy for anxiety symptoms in cancer survivors. And we know individually they're all helpful, but then are there certain type of patients who may benefit from what we don't know? So only by research we can better understand. In terms of the whole package program, I'm aware of one study done by Claudia Vid in collaboration with a group in Italy. They look at doing class randomized trial for women with breast cancer to have package of like massage, acupuncture, mind body treatment versus usual care. They found overall improved quality of life. So that's the only thing that I'm aware, but I don't know whether I know everything. So I do think that area is needed, but I feel like for me, intellectually, I'm more interested in this, what I call the concept of precision, integrated oncology, to really identify what treatments are particularly good for whom at what time junction.
Fantastic. There are a lot of practical questions here. People really impressed with your program, people asking how to get in touch with you, they have patients. But some really important questions I think that we struggle with here is, how are people's access to these therapies supported at your clinic and at your satellite clinics? Is it largely out of pocket? Is it covered by philanthropy? Does insurance cover these things? How does the average person access this?
So Peter, this is the question we all struggle, but I do feel like the field is moving towards the right direction. So in our center, all the physician consultations as well as nurse practitioner are covered by the insurance. So if you have insurance, you can come to MSK, you can come to see us. And that has been really helpful. Unfortunately, our integrative medicine approach currently are all fee-for-service. Patient can submit for reimbursement. Some insurers do pay for them. We are actually looking for practice like acupuncture, because Medicare just made a change to look at how to cover this under insurance. So we're in the beginning phase to learn. And this year, building on the success of our integrated medicine program at home, I was able to get a donor to really help us to begin building a program called the Health Equity Integrated Medicine. So we're going to probably partner with some of the underserved hospitals in the New York metro area to begin building integrated medicine programming for patients from underserved area. At the beginning step, we want to do some community engagement, understand what actually they want and what they need, because what works for a highly educated population, you cannot assume just shift that to make available people from that community want. So I think once we learn a little bit more what kind of programming they want and whether we need to make some culturally appropriate tailoring in the programming, then I think we're going to hopefully launch it at the beginning of next year. So I do think this is an area integrated medicine has a lot of room to improve. I don't think we're particularly good at doing health disparity or diversity work. I do think for young researchers who have interest in this area, this is really an area of tremendous opportunity.
I think I echo that comment and commitment, and I'm impressed by how much qualitative work you've done and how you've tried to bring patients' voices and preferences into the questions that you ask in your research and the programs that you've developed. So I think you've modeled that beautifully in your programs, but also in your presentation today. So thank you for that. There's a number of other practical questions. One has to do with studying vitamins and high doses of vitamins like and supplements like lipoic acid. Does your group address any of those kinds of questions?
Unfortunately, this is not an area we have any active research going on. So I think when you build an academic program, you need to choose what to focus, because integrated medicine has so many different areas. You cannot be an expert for all. So that's why when Peter asked me to present, I said my research a lot is focused on acupuncture, at least today. Like maybe 5 years from now, I have other things to present. So I just think staying focused is a key to really building depth. So I do think there are other groups looking at high dose vitamin C or vitamin D for specific cancer treatments. I do think, even at MSK, I think there are people potentially are interested in high dose vitamin D for specific conditions, but they are really studying this from a pharmacological perspective rather than as a supplement perspective. I do think that's probably where the direction should be to really have meaningful results. I think it just oral intake, you really need a huge population study. I don't know whether there's certain design or funding for that kind of work to yield meaningful results.
Yeah, great point.
And Peter, I want to talk a little bit about method. I was actually talking to a colleague who is just in cancer care delivery, talk about the challenge of herbal research. Because herbs, I think, probably are generally safer than most of the investigational drugs because they're used for a lot of time. They're currently being used. But their efficacy probably much smaller than the traditional margin we look for drugs. So from a statistical way, you need much larger sample size to do a study, even say you have the right product. Unfortunately, that's what herbal researchers, we don't have. The federal government don't like to fund natural product trials. Industries have no incentive. So we just left our patients in the dark, right? I don't think that's right. So that's why I'm going to write some papers. Hopefully, Peter, you'll join me to make the case. Somebody has to study, even we find it's ineffective. That's good news too, right? That's helping patients to learn. But just afraid of doing the research, that's probably not an option for our patients.
Yeah, I think part of the history that, early work by Rob Saper and others at the Osher Center, but also other, researchers have highlighted that in the past, many herbs were contaminated with pharmaceutical drugs or had some toxins, heavy metals and things like that. I think that's changed a lot, and the quality of these herbal products and the pathway that they go through in order to make it to hospitals like yours are very different now. So, but I think that has also deterred interest in research in the past, and I'm glad that that's changed. I'm going to say that that was the last question. There's many more, which is really a testament to how engaging you were and the interest in this topic. So I want to thank you for such a great presentation and for your time and putting it together and all the great work you do. So I'm sure if we were in an auditorium that was filled, you'd hear a rousing round of applause. So I'm just going to do this and thank you. I also have a couple comments to close our session with. So just want to make a few announcements. Next month, and hopefully you can join us, Jun, we have another Grand Rounds on October 5th, and this one's going to be a special presentation. It's going to be the inaugural named Jack Hogan Lecture, which is from this year forward going to be an annual event, and it honors Mr. Hogan, who's a remarkable man and was a grateful patient at our clinic that's deeply committed to physical activity and exercise and healthy aging. Our presenter, Dr. Ayman Lee, is a world-renowned authority on exercise and health, and will be presenting a lecture entitled, "Why Should I Bother Being Physically Active?" And just want to note that this Grand Rounds is going to happen at 4 o'clock in the afternoon on the 5th, as opposed to our normal 8 a.m. time. I also want to remind everyone that our pilot research grant application system is open, so please send in your letters of intent. That'll be open through December. And also our NIH-funded T32 research program, the Harvard Medical School Research Fellowship in Integrative Medicine, led by Gloria Ye, is also accepting new applications, and those are due on the 12th. So you can learn more about all these programs, view this lecture or pass it on to friends and other archived Grand Rounds, and even make a philanthropic donation to the Osher Center by going to our website, oshercenter.org. So thank you again, Dr. Mao, Jun, for joining us today, and thank you all for participating in this excellent event. Hope to see you next month.
Thank you all.